And welcome back to Med School Radio. We're talking about thrombosis and hemostasis. In this third part, we're going to continue with our case discussion, and we're going to start with a discussion of thrombotic thrombocytopenic purpura, or TTP. TTP is a rare consumptive thrombocytopenia in which platelet aggregations on the microvascular endothelium result in a pentad of symptoms and signs: thrombocytopenia, anemia, fever, renal and neurologic abnormalities. Fortunately, all 5 abnormalities occur infrequently, and most patients have hemolytic anemia and thrombocytopenia because of early recognition and therapy. In the past, renal involvement with proteinuria, hematuria, and azotemia occurred in greater than 80% of patients. The breakthrough in understanding of this disorder was the finding that some patients with recurrent TTP have very large multimers of von Willebrand's factor. Recall that von Willebrand's factor, along with GP1P, serve to bind platelets to exposed collagen of denuded vascular endothelium so that primary hemostasis can commence. These larger multimers in patients with TTP are even more efficient at binding and activating platelets than the smaller or normal multimers. Investigations found a deficiency of metalloproteinase, which has been named ADAMTS13 or ADAMTS13, a disintegrin-like and metalloproteinase with thrombospondin type repeats. Further, many patients with adult onset TTP have developed an antibody to ADAMTS13 that severely compromises the activity of the enzyme. It is clear that either inherited or acquired deficiencies of ADAMTS13 allow ultra-large multimers of von Willebrand's factor to accumulate. These giant multimers ensnare excessive numbers of platelets, leading to vascular occlusion. Now let's talk about the clinical manifestations of TTP. In contrast to most patients with thrombocytopenia who tend to have excessive mucocutaneous bleeding, patients with TTP are more prone to thrombosis than to bleeding. Thrombosis occurs in arterioles and capillaries, and clots are composed mainly of platelets containing little fibrin, as in a normal clot. Platelet counts are decreased, but if TTP is diagnosed promptly, very low counts do not occur. These thrombotic events can cause abdominal pain from intestinal ischemia and neurologic signs and symptoms. Another feature of TTP that sets it apart from other more typical cases of thrombocytopenia is microangiopathic hemolytic anemia caused by cell fragmentation owing to physical damage incurred when red cells flow past the platelet plugs. I just want to confirm that I'm understanding this. So again, let's talk about the clinical manifestations. So in contrast to most patients with thrombocytopenia who tend to have excessive mucocutaneous bleeding, patients with TTP are more prone to thrombosis than to bleeding. They're more prone to thrombosis than to bleeding. Thrombosis occurs in arterioles and capillaries, and clots are composed mainly of platelets containing little fibrin as in a normal clot. Platelet counts are decreased, but if TTP is diagnosed promptly, very low counts do not occur. These thrombotic events can cause abdominal pain from intestinal ischemia and neurologic signs and symptoms. Another feature of TTP that sets it apart from other more typical causes of thrombocytopenia is microangiopathic hemolytic anemia caused by fragmentation, owing to physical damage incurred when red cells flow past the platelet plugs. Now let's talk about the treatment of TTP. Prompt diagnosis and treatment with plasmapheresis has had a dramatic effect on survival. Before plasmapheresis, mortality from TTP was 90%, and with prompt therapy, mortality has fallen to 15%. Now let's move on to talk about hemolytic uremic syndrome, or HUS. While there are some similarities between TTPS and HUS, points of distinction include the fact that HUS occurs primarily in infants and young children. Neurologic abnormalities are absent, and HUS is not caused by a deficiency of Adamantase 13. Further, as the name suggests, acute renal failure is a defining feature of HUS. Similarities between HUS and TTP are that both syndromes have thrombocytopenia, although milder in HUS, and both produce microangiopathic hemolytic anemia. Shiga toxin producing enterohemorrhagic Escherichia coli have been convincingly implicated in the pathogenesis of HUS. Hamburger contaminated with E. coli, or 0157H7, has been a major vehicle of bloody diarrhea that is followed by renal disease. The Shiga toxin causes direct damage to glomerular endothelial cells, causing platelet adhesion and trapping of erythrocytes. Tacrolimus, cyclosporin, mitomycin C, cisplatin, and bleomycin have been associated with HUS. These drugs are believed to act by damaging endothelial cells. Prevention by adequate cooking of hamburger and other potentially contaminated foods to destroy the toxin is the most effective approach. Antibiotics and anti-motility drugs do not appear to decrease the incidence of HUS. Plasmapheresis has only been effective in atypical forms of HUS caused by inherited defects of the regulation of the complement cascade. Now let's discuss hereditary disorders of platelet function. Defects in platelet adhesion, platelet aggregation, and secretion, so-called storage pool disorders, represent the heritable defects of platelet function. As a group, these disorders are rare but have yielded much information about platelet function. Of this group, platelet secretory disorders are the most common. The secretory disorders are a broad category including cell signaling defects and deficiencies of dense bodies, A granules, or both. The clinical manifestations of these disorders, all of which render the platelet dysfunctional, are similar to those which occur with thrombocytopenia, that is, mucocutaneous bleeding, and includes petechiae, ecchymoses, epistaxis, excessive menstrual bleeding, and continued bleeding after trauma or a surgical procedure. Abnormal laboratory studies include a prolonged bleeding time, which is nonspecific, platelet aggregation studies including various agonists, epinephrine, ADP, collagen, and ristocytin provide a profile of curves that will detect most of these disorders. Now moving on, we will discuss Glanzmann's thrombasthenia. Glanzmann's thrombasthenia is a rare inherited disorder that is characterized by abnormal platelet aggregation in response to all agonists except ristocytin. Platelet aggregation requires fibrinogen and the GP2B/3A receptor on the platelet membrane. In the absence of either of these essential components, platelets will fail to aggregate. In Glanzmann's thrombasthenia, the platelets lack the GP2B/3A complex that is the site of attachment of fibrinogen to the platelet. Ristocytin, an antibiotic that was withdrawn because it caused thrombocytopenia, causes a platelet aggregation that requires the presence of von Willebrand's factor multimers. Predictably, this test will be abnormal in von Willebrand disease, von Willebrand's vita infra. How about Bernard-Soulier syndrome? Bernard-Soulier syndrome, or BSS, is an autosomal recessive trait that is characterized by mild thrombocytopenia, giant platelets on the peripheral smear, and a defect in the platelet GP1b-5-9 complex. Consequently, just write this down. Consequently, the platelet aggregation test is abnormal with ritocetin, but normal with ADP, collagen, and epinephrine. One more time. Consequently, the platelet aggregation test is abnormal with ritocetin, but normal with ADP, collagen, and epinephrine. So to distinguish between von Willebrand's and BSS, a test system containing von Willebrand's factor is added to platelet suspensions. The normal plasma will not correct the ritocetin aggregation in BSS because there is no receptor for von Willebrand's factor, but will correct the aggregation in von Willebrand's disease because the test system supplies the missing von Willebrand's factor. Try to say that backwards. Storage pool defects. In platelet aggregation studies, there is often a small primary wave of aggregation that occurs when the platelets respond directly to the aggregating agents, and usually entails formation of small aggregates. Normally, this is followed by a second wave of aggregation, which represents complete aggregation and is usually triggered by release of endogenous ADP from platelet-dense bodies. It follows that with deficiencies of the dense granules, also known as something storage pool disease, the primary wave is present with exogenous ADP and epinephrine, but because there is no intracellular ADP in platelets, the secondary wave does not occur. This defect is inherited as an autosomal dominant trait and tends to affect women because of excessive menstrual bleeding. It has been described in Hermansky-Pudlak syndrome, Chidiac-Higashi syndrome, and the Wiskott-Aldrich syndrome. The gray platelet syndrome is caused by deficiency of A granules, alpha granules, which in their absence impart the gray color. The gray platelet syndrome is an autosomal recessive trait and is usually associated with mild bleeding. A carefully prepared blood smear should reveal the color defect. And now we will continue with von Willebrand disease. First described in 1926, von Willebrand disease is characterized by mucocutaneous bleeding with petechiae, epistaxis, GI bleeding, and menorrhagia. The most common form is inherited as an autosomal dominant trait, and it is usually the result of a decreased synthesis or a qualitative defect in the von Willebrand's factor. So von Willebrand's disease is the most common hereditary bleeding disorder, but because the symptoms of von Willebrand's disease are not as dramatic as those of hemophilia, and because von Willebrand's disease is not associated with a role in the downfall of the Russian Tsar, as is hemophilia, von Willebrand's disease has not achieved the same notoriety. Von Willebrand's factor is synthesized in endothelial cells and megakaryocytes, where von Willebrand's factor is stored in Weibel pallidate bodies and platelet A granules.